I am here with Dr. Brian Sass. And Dr. Sass has been working with the most complex patients from all around the world and is a fellow of the American Board of Brain Injury Rehabilitation. He graduated from Michigan State with honors in 2011 with a bachelor's degree in human physiology. He graduated magna cum laude from Life University in 2015 with a doctorate of chiropractic. He was awarded a certificate of merit in contemporary scientific paradigms from Life University. In 2015, he received fellowships in brain injury rehabilitation as well as a diplomate in functional neurology from the American Chiropractic Neurology Board. He is also a certified functional medicine practitioner. Over the past 8 years, he has taken thousands of hours of courses offered by the Carrick Institute of Graduate Studies, focusing on neurology and patient-centered rehabilitation, and he currently works at Midwest Functional Neurology Center. So welcome to the summit. So happy to have you here, Brian.
Thank you for having me, Amy. I'm very excited.
And today we're going to be talking about dysautonomia. And I really think this is such an important topic in the brain injury community. I think a lot of people have it to some extent and don't know that they have it. They know something's wrong, but, unfortunately, it's so commonly missed. So really excited to have you here and just talk about it today.
Very cool. So let me go over the goal of my presentation here. So just like what you just said, I think dysautonomia is one of those things that underlies a lot of conditions, especially concussions, and it's usually missed or it's misdiagnosed, and therefore it's just not treated appropriately. And sometimes people just don't get better and they have something underlying that just lingers. So my goal is to go over what dysautonomia is, how you can evaluate or test for it, and then most importantly, how we can treat it and make it better.
Awesome.
Cool. So let me start off with a story. And this is kind of an unfortunate story, but it's a good story because I think a lot of people fall under this category. So there's a person named Tori Foles, and she has dysautonomia, and she got a little bit of popularity because her husband was the Super Bowl MVP last year for the Philadelphia Eagles. So her story is, in her early 20s, she started developing these symptoms where she just felt faint, almost like she would fall down, was dizzy constantly, almost every minute of every single day, and she was severely fatigued. So normally, or naturally, she knew something was wrong, and she went to the doctors to figure out what's up, like what should I do about it. And she went to a few doctors, and they just couldn't find anything. They're like, we can't, nothing's wrong, nothing's coming up. We did all these tests. We found nothing. And one doctor actually told her, and I quote, "You look young and healthy and in perfect condition. Have you looked into anxiety or depression?" So basically, there's something going on that's severely affecting her. She doesn't know what it is, and no one can find it. And what most people do, or what most doctors do, unfortunately, is they try to attribute the symptoms to something. And if they can't see it, they just say, oh, it must be psychological or it must be anxiety. And what happens is these people know, they're like, I'm not anxious, I'm not depressed, it's not me, but there's something wrong, and then they have nowhere to go. So luckily for her, she was her own advocate and kept pushing, and then she finally got an accurate diagnosis and then was treated for it. But I think the most important thing about her story is, and why it was so popular and why it's good to know, is there's a lot of people that go through very, very similar things, meaning they know something's wrong, they have no idea what it is, and they try to figure it out, go to numerous doctors, and they're just baffled. Like they don't know what to do, and it's just like a vicious cycle of feeling terrible and not getting anywhere.
Mm-hmm.
So one of the hard things with dysautonomia is you can't see it. So unlike a broken bone when you're in a cast, or if get in a car accident, you have a huge scar on your face, people can look at you and then think that you're normal, like you can't see it. It's almost seemingly invisible. So you have to do special things to test for it. Otherwise, you'll never know if it's there. So sometimes it's misinterpreted not only by doctors, but especially family, friends, and coworkers. They're like, oh, so-and-so's lying. Like they look fine. They're smiling, or, they don't look sick. So people sometimes attribute it to just making things up or just anxiety or things like that. And it's very frustrating. It's hard. It's its own kind of mental hurdle to try to deal with all that along with the symptoms that go along with dysautonomia. So one more thing on this point is there was a large POTS survey. So POTS is a type of dysautonomia that I will be talking about later, but they surveyed 4,200 people with POTS, and they found that out of those 4,200, 75% of them were told that their symptoms were psychological, that there was nothing wrong with them, it was all in their head. And out of those 4,200, 25% of them were treated for a mental illness, were actually treated for something that wasn't causing their symptoms. And they found on average, the average person there saw at least 7 doctors before an accurate diagnosis and over 4 years until they were accurately diagnosed. So obviously just by those numbers, just goes to tell you there's a desperate need for better evaluation and better management of this, because 4 years is way too long, 7 doctors is way too many. And this is something that's physiological, meaning there's something happening in your body that's causing the symptoms instead of being psychological. So it's something that shouldn't be misinterpreted and can't be missed, because if you don't find it, it'll just cause more problems because it won't be treated right.
And, I think the vast majority of brain injury people listening, they're going to relate to that. I went 2.5 years. We knew I had a concussion. Nobody really referred to it as a brain injury. But, give it more time. Give it more time. Yeah. And eventually, I think you're just, maybe making this up. I think maybe you're just depressed. You need some antidepressants.
Right.
And, you start to think you're crazy because nobody believes you.
Right.
So, yeah. And what, I don't know if you know the statistic, but in your own experience, working with people with brain injury, like what % do you think have a dysautonomic problem?
It's a great question. And I looked for, in the research, if I could find any percentage of this or that, which, I couldn't find anything substantial. There's a lot of case studies and things that talk about it, but not like a large group study like the POTS one I just talked about. But in my own experience, watching other doctors treat concussions, even myself treating people, it's at least 50%, if not more.
Mm-hmm.
It's not always there, but more often than not, it's at least a component. Usually secondary to other things, which I'll talk about, but it's still something that if you don't address, it's just something that I think takes away from full resolution, and it's not something that just gets better in time. Sit and wait, it'll get better. Just wait. I'm not of that mindset. And it's something that there's certain things that, in my opinion, you should do to make it actively go away, or to really treat it and make it a physiologically normal response instead of the sit back and wait. But anyway, there's a great number of people, more often than not, if they're concussed or have some sort of brain injury, there's usually at least an aspect of some dysautonomia. Sometimes it's really severe and it's one of the main things. Other times it's kind of secondary in the background, but it's something that it's there pretty often.
So why don't you go ahead and jump in, what is dysautonomia? What are some of the symptoms to look for that people listening probably have some of these symptoms?
Right. So dysautonomia, by definition, is dysfunction of the autonomic nervous system. So what the autonomic nervous system does is it regulates involuntary functions, things you don't think about, like your heart rate, your blood pressure, your pupil dilation, the vasodilation, like how big your arteries are, things like that. And the best way that I've ever heard someone they talked about dysautonomia in a simple statement. They said that the autonomic nervous system controls things you don't think about, but if it becomes dysfunctional, you can't think about anything else.
Yeah.
And it's something, because just if you read the definition, you're like, oh, my heart rate gets high or my blood pressure is this, and it doesn't sound bad, but it has far-reaching and life-changing or devastating effects, which I'll talk about in just a second. But so one thing about dysautonomia is it's an umbrella term, meaning it encompasses a wide variety of different syndromes. It's not like one thing. So someone might have dysautonomia and have a certain type of it, when someone else comes in and it's a little bit different. It's expressed differently. So the autonomics, it's really made up of two parts, and I'm going to make it really simple. One part turns everything on. It makes your heart rate go up, makes your blood pressure go up. It makes your blood vessels constrict to move your blood places. And the other part turns everything off. And in a normal person, what the brain does is it regulates those two systems. So those two systems are basically on at some level every single day. And then depending on what you're doing or what your brain wants to do, it can alter one to make it higher and one lower, make them both go up, make them both go down, relatively change it. And it's all a balance, and it's all a regulation control system that should be very efficient and very stable. And what happens with dysautonomia is one or two of those systems becomes dysregulated or dysfunctional, and it's either hyperactive or it's underactive and it's not doing what it's supposed to, and that's what causes all the symptoms. So before I go into symptoms, I do want to talk a little bit more about just generally speaking what the autonomic nervous system does. Because again, more than just regulating your heart rate or your blood pressure, if you can imagine that you're graduating, whether it's high school or college, and you're standing in line and then like the president's up there, the whole spotlight's there, you have this huge auditorium, this huge crowd, you hear your name over the loudspeaker call, you're like walking down, the spotlight's on you, everyone's clapping, and you have that like huge pressure feeling, and you're like super happy that finally like you accomplished this thing and it's over. But that internal feeling of like joy and suspense and accomplishment, that's all your autonomics. So it's a full body, like perceptual sensory feeling. Just like if you can imagine you're watching your firstborn child ride a bike and every hair on your body's standing up in apprehension, hoping that they don't slip and fall, or you're in like a haunted house and you know that something's going to like jump out and scare you and you're like waiting. That kind of feeling, that's what the autonomics do. So what happens is if that gets dysregulated, think about having things like that just run rampant or just chaos constantly, and you're just walking around dealing with that when it's not supposed to be on. That gives you a better idea where some people just feel crazy, for lack of a better term. They just feel off. They don't feel like themselves. And they're like, I don't know, like I feel weird standing up, lying down. Like it just doesn't feel right. It doesn't feel the same. It never goes away. It's constant. So that's as good an example as I can say of what it really regulates more than just heart rate and blood pressure. It's a lot more involved in that. But specifically in terms of symptoms, there's three of them that are the most common. And not everybody with dysautonomia will have these, but these are the most common. The first one is a constant headache. So I've had a lot of people come in and they're like, I have a constant headache. And I've been told by other people that it's impossible to have a headache constantly, because traditionally headaches are, tension headaches or migraines are on and off. Sometimes you don't have them, and whatever triggers it starts it, you have a headache, and then you wait some time, sleep, whatever, and then it goes away. They're like, I have a headache constantly. And yeah, it goes up and down, but pretty much throughout the day it's there. And it's something that's pretty specific to like dysautonomia, which I'll go into later why. But if anybody comes in with that, it's highly likely that they have something going on with their autonomics that's not right. The other one's brain fog. So brain fog can be caused by a lot of different things, but that kind of misty, aloof, spacey feeling where you just don't even feel like you can't think, or even sometimes you don't feel grounded, like you're just sifting through a mist where even in your thoughts, it's not just like movement, feeling like a little off balance or things. It's like in your head. People are like, I feel like there's clouds in my head and I can't pinpoint things. Like if I'm trying to say certain words, or I'm trying to be actively engaged in a conversation or pay attention to a TV show, it just feels like everything is just spacey. Now, that can be caused by a lot of different things, but a lot of people with dysautonomia have brain fog as well. And the last one is lightheadedness, or most people say dizziness. There's a lot of different kinds of dizziness, but there's two main types. One of them is spinning, the sense that you're spinning or the world's spinning around you, and that's more of a vertigo kind of feeling, and that usually has to do with the inner ear, something wrong in that system or the inner ear itself. But with dysautonomia, most people feel lightheaded. So they don't really feel spinning usually, but they feel lightheaded, like they might faint or they might fall, or they just feel very, very weak, especially with changing positions. So a lot of these people, without even knowing it, and I've had a lot of people tell me that they just attribute it to old age, or it's just like the normal thing, is every single time they sit up, they have to sit there and wait for the head rush and that lightheadedness to pass for like a couple minutes. They're like, oh yeah, it happens all the time, but it's normal. I'm like, it's not normal. So what happens is, as they get lightheaded, which I'll go through the mechanism of why that happens later, but that lightheadedness specifically, so it's dizziness, it makes you feel dizzy, but it's more of a lightheaded or ungrounded or weak feeling than true spinning. Those three are common, but also with that, there's a couple other ones that are usually common: blurry vision, fatigue, coldness in your hands and feet, emotional changes, usually frustration or sadness, sometimes sleeping, insomnia. Then there's also other ones, but those are the main ones, like the constant headache, the brain fog, and then the dizziness or the lightheadedness.
I remember for me, I would get up off the couch. So in my building, the mailroom was quite a ways away. It was like 1,000 steps there and back. And I remember I'd get up, get out of my apartment, walk down the hall, get like halfway to the mailroom, and I'd feel like, oh, like I think I might pass out. Like I'd have to kind of like grab I never did pass out, but it was always this feeling like I might black out. And I didn't make that connection. Like I thought I was maybe having some sort of weird seizure or something. I didn't make the connection, well, obviously till much later after meeting Jeremy, but that was dysautonomia, and that it could have that long of a what's the word I'm looking for? But from the time you would think you'd feel lightheaded when you first get up.
Right.
Delayed onset. Is that the word?
Yeah.
Close enough.
That's a good way to put it. Well, I'll talk about it later, but like with POTS, which is one type of dysautonomia, by definition, it's a spike in your heart rate that either happens immediately or up to 10 minutes. So
wow.
So it's something that usually, more often than not, people feel it within like the first minute, or they get their symptoms like within the first minute. But a lot of the times, kind of like what you said, you might feel fine and then you're just walking around and then it hits you. So it can definitely.
And it's scary. It's like, what is wrong? Like, I mean, it was like almost every time I go to the mailroom, you know? So it's really scary.
Yeah, well, for sure. So next, what I want to talk about, so again, dysautonomia is the umbrella term, meaning it's just a general term that kind of encompasses a lot of different types. I want to talk about one type, and that's called POTS. So to me, POTS is one of the most common, especially with brain injury. So I want to kind of focus on that one. So what POTS is, what it stands for, is postural orthostatic tachycardia syndrome. And if you break it down, basically what it means is that when you stand up, your heart rate spikes up too high, and it's usually triggered by a change in position. So by definition, what it is it's a heart rate spike of more than 30 beats per minute. Normally, when you stand up, your heart rate should increase, but it really shouldn't go more than 20, where 20 to 30 is functionally not great, but more than 30 by even medical definition is way too much, and it's termed POTS. So looking at just the common accepted understanding of POTS is it's widely accepted that it's a disorder of gravity integration, meaning that just the influence or the stress of gravity by changing positions is too stressful or it's too overloading on your system, and that's what causes the heart rate spike. So it's important to know, because when we talk about treatment, we actually do something treatment based on the mechanism instead of just management, which I'll get into. But the best way that I can describe POTS is a metaphor, because I try to make it more easier to understand. So if you can imagine like an exercise ball, like those big yoga balls, or like I think they call them Swiss balls sometimes, like the ones that you have to pump up. Think about the pumping action, or pumping that ball full of air, as the job of the brain moving blood around. So normally, what the good exercise balls have is they have like a pressurized air pump that you turn it on, and it's like 20 kilowatts, and it like pumps it up in like 30 seconds and it's full. That's like a normal human being, meaning as you change positions, you start to exercise, you're stressed out, your brain uses that like pressurized pump, moves blood where it should, and then you're fine. What happens with POTS is when that system becomes dysfunctional, it's almost like you're using one of those hand cranks or those hand squeezes that takes like 30 minutes to pump those
It
things
goes
up.
like for an
Yeah.
hour.
You're sitting there just grinding away, pumping that thing up.
Done
Think
that.
about that every single time that you stand up or you exercise or like you get stressed out and then your brain realizes like, I got to move blood now. And then there's that thing in the background just pumping away, working really hard, fatiguing out, not moving blood efficiently. That's what POTS is. That's the best way that I could describe it because it's kind of a complex thing. I mean,
That's a great analogy.
it's oversimplified a little bit, but that's kind of how it is. And that's why people just standing up and moving around during the day, by like 3, 4, 5 o'clock, they're done. They're like, I'm exhausted because just defeating gravity is like so challenging for them that they're just spent by the end of the day. But the actual mechanism of POTS, just to get a little bit more into it. So again, POTS is diagnosed or it's evaluated by changing positions and looking at what the heart rate does. So what happens is, as you're lying down, everything's at rest. So your heart rate, it's at a certain level, it's just resting. And then as you stand up or as you become upright, the influence of gravity changes. And what happens is blood, it gets pulled down from gravity, so it goes down to your feet. And then what happens is, since blood's going down, it's leaving your brain. And your brain gets signals from different receptors saying, I'm losing blood. And the brain needs blood, so it says, I need to pump some more up. So it sends signals down to the heart to pump more blood up. So it basically makes the autonomics turn on to pump blood back up. But what happens is, if those brainstem areas are dysfunctional and it can't regulate or it can't control those signals efficiently, those signals become skewed and the heart rate jumps up too much. So it spikes. So again, it's supposed to go up a little bit because it needs to pump blood back up. But if it goes up too fast, why that's bad is when the heart rate spikes too fast, the heart beats too quickly. And what happens is, like, the blood can't fill, or it doesn't have enough time to fill with blood. So the actual output of blood from the heart goes down. So even though like the heart's pumping really fast, which you would probably think that, oh, it must mean that I'm getting more blood, it's actually less blood to your brain and body because the heart can't fill with enough blood to pump it, and it's just tacking away so hard that it's a decreased oxygen saturation to your brain and muscles, and that's what causes the lightheadedness. So what happens is, again, usually it's immediate, but sometimes it can be delayed, that as you stand up, if it's somewhat stable, it's kind of pumping and it's fine, but then it fatigues, the signals get screwed up, that system spikes up, the heart rate spikes, blood doesn't move appropriately, and then you get the symptoms of lightheadedness. Does that make sense, Amy?
Mm-hmm.
Kind of a lot, but that's like
it is. And I get it. It's kind of a complicated thing, and it's complex, and that's why a lot of doctors are missing it, right? Like,
it is.
They don't really know what to look for, and I think for a lot of patients, it's hard to explain what's wrong with you because you don't know, right? And the longer a condition goes on, like, you're talking earlier, 4 years it took her, that's when, like, you do start getting anxiety and you get all these other things going on because you're stuck in that on position, right? And it's such a vicious cycle. So that's why this is so important for people to understand it.
So just on the anxiety topic, because I find it interesting. So I think of anxiety as there's two main groups. One is like primary anxiety, meaning you have a neurochemical dysregulation that causes anxiety, and that kind of starts, like, that's the primary thing, and it causes other things.
Mm-hmm.
And usually, and that's what doctors try to attribute people with POTS having because they can't find anything else. But usually, especially with concussions, anxiety is secondary for one of two reasons. What happens is, like, if you have symptoms for a certain amount of time, sometimes even more than like a couple months, you start being anxious because you're like, this is my life now. Yeah. Like, I have to learn how to live with these symptoms, and that makes you anxious because you're like you feel helpless, you feel hopeless, you're like, I don't know what to do, and this is just my new life, I can't do anything, no one knows what to do, and you're just helpless, and believe me, that creates anxiety. Mm-hmm. Other times, like with POTS, it's a disorder or it's a dysregulation of that on system, which is basically your stress system. So the stress system or the stress response, no matter what triggers it, meaning if you're exercising or, you have family stress or, you didn't sleep right and then you're fatigued, like if you're stressed out, no matter what triggers it, it's the same physiological response in the body. And what happens is, like, if that stress system's always on or it's hyperactive, it's not regulated, that can create anxiety because it's not supposed to be on the whole time. It's almost like you're running a marathon and every second of every single day, and you get no rest. After a period of time, even a couple of days, like, you're going to feel anxious because your body's like ready to like run or fight for your life, and it's supposed to be just relaxing on the couch. So what happens is if it's there for a little bit, some anxiety will be there, either from like the helpless feeling or just from the physiological response, but it's different because you wouldn't want to treat the anxiety because that's not causing anything. It's a compensation. Right. That's a secondary effect from the POTS. Right. So, but the good news is in terms of just evaluation or testing, I think that it's not so difficult. There's just a lapse of knowledge, meaning most people just don't even know about it to check for it, but it's not super difficult. So for POTS, what you would do very simply is you just have someone lie down, look at their heart rate, have them stand up, and just check the heart rate while they're standing. It's that simple. And if it spikes more than 30, it's POTS. Now, what's hard with dysautonomia is, as I said before, there's different kinds. So just really quickly, different kinds of like dysautonomia is there's one kind where I call it like a resting dysautonomia, where we check the blood pressure seated on both sides. And very commonly after concussions, it's very common for one side to be more than 10 points higher than the other. And it should never be that big of a difference. It should be relatively the same. But sometimes people are just sitting there and their blood pressure is higher than on one side, like significantly than the other. And that's not good. But it's different than POTS because POTS doesn't cause that. Mm-hmm. Other times what happens is, like, if you check the positional changes lying to standing, sometimes the heart rate spikes, but so does the blood pressure. So that's different than POTS because POTS is just a heart rate thing. It doesn't affect the blood pressure significantly. I mean, like, it has an effect because it's still the autonomic system, but it's usually the heart rate. That's the pathological response. Other times people stand up from a lying position and their heart rate and their blood pressure drop. And that's different, and that's called vasovagal, and these are usually people that faint. So most of the time with POTS, kind of even what you said, is you'll feel lightheaded and you'll feel like you fall, but you usually don't, or most people don't. Sometimes they can. But vasovagal, that's when you have like a drop attack, where you stand up and you lose all control and you just fall. So how you really need to evaluate dysautonomia in general is you need to do positional vital testing. So we have people come in, they sit down, we check blood pressure on both sides, check the heart rate, have them lie down, wait a few minutes, check both sides again, blood pressure, heart rate, and then we have them stand up. And then we just look at it and say, is it normal or is it abnormal? It doesn't take that long. And it's something that we do on everybody because it's something that even if you're like, I have vertigo or I have something that doesn't sound like dysautonomia, it still might be there. So, it's not, you don't need crazy expensive equipment to test for it. And it's not so subtle that, you have to be trained years and years to find. It's just something that you have to know of and then just make the effort to actually check for it.
And what about the tilt table? Or are you getting to that with
the which I'll talk about that in treatment.
Okay.
So my next part that I want to talk about is the treatment, and this is where I get a little bit more into my opinion. So again, there's different schools of thought, but I'm going to tell you what I believe in and why we do it the way that we do it and why. But there's different schools of thought. So just from a testing standpoint, there's some clinics that do test diagnostically through the tilt table. I don't do that because most people feel terrible after they do it. When we do positional testing, it's quick. They might get lightheaded or okay, sit down, and then it just passes. With the tilt table, what they do diagnostically is they'll start at 0 degrees, like flat supine, and then they'll slowly crank you up, and then they'll check the vitals. Now, it's not a bad idea, meaning, which I used to do that, but I found that people just feel terrible doing that. And why they feel terrible is there's usually an angle that at a certain angle, when the influence of gravity changes, there's usually a certain point when it overloads or it fatigues the system, or it's just like that. It's just too stressful on the body where it breaks down. What happens with the tilt table testing is they'll hold you there, and then they'll go up and they'll hold you there. They'll go up and they'll hold you there. And usually it's like once it breaks and all the symptoms happen, and then like it just escapes, and then they just hold you there, you're just going to feel terrible. And it's something, and why it's hard to treat is it's a delicate balance of, you don't want to irritate the system, but you want to train it, or you want to treat it without just flaring the system up or fatiguing it out, because one, the person will feel terrible, but then two, it's like you're not doing anything therapeutically to actually help it heal or help fix it. You're just inflaming it. So I don't normally do the tilt table in terms of testing, but we do it in terms of treatment. So let me talk about treatment. The common things most people do, like if they come in with POTS, like if someone's ever even heard of POTS, or I ask them, like, what do you do for it? It's usually just management, which I don't necessarily agree with, because I think there's things that you can do therapeutically that can actually train it to actually fix it, or at least make it better. So most people come in with just management strategies, which aren't bad, but they're not necessarily fixing the problem. So
Right.
what most people do traditionally is they'll increase their salt intake, they'll increase their water intake, and what that's supposed to do is it just helps increase the blood volume. So it can help move blood, just because if there's a higher blood volume, it usually means there's a higher blood pressure, which means that blood's moved a little bit more efficiently. But again, having higher salt, or just having being hydrated, it's not gonna fix the dysregulation of gravity that your brain can't do. It might help, but it's never going to fix it. So the other thing most people do is they wear compression socks, which I'm not a big fan of, because I don't really think that they do too much. But what the mechanism is there is, if you wear compression socks, it's a mechanical pressure that helps push blood back up to your thorax or brain by just compressing the veins and pushing blood back up. But again, it's not going to fix anything, because it's not really changing how your brain regulates gravity. It's just mechanically trying to push blood up. Still not a bad idea, but again, it's more of a management thing. And then other times people try medication, which usually, at least in my experience, doesn't work that well, because again, it has no influence on gravity. It usually tries to change like the receptors, meaning like they try to make your blood pressure change, or just try to change the autonomics through different receptors, which can help. So it's not a bad idea, but I've never met anybody that has taken medication, they're like, it cured my dysautonomia.
Right.
It might help, which is great, but usually if it's something that can be fixed or made even better therapeutically through different exercises and treatment, which I'll get into, then it's like medication is not really needed, because again, it's kind of masking, or it might help, but it's not fixing it. And lastly, and my personal favorite, is exercise. So I get a large number of people come in with dysautonomia or POTS, and they say that they've been told that, I just want you to exercise. So they try to go out and exercise, and they fail, and they feel terrible. And it's the athlete's mentality of, if I feel bad, push through it, because it'll be better. If I'm sore, I'm tired, just keep pushing. Pain is weakness leaving the body and all that. Unfortunately, dysautonomia is not like that. Meaning, like, if you get fatigued or get lightheaded or you get this brain fog and all this other stuff, you can't push through it. So I do believe in exercise, but there's a certain timing to it, and I have a certain way that I find works well with people, like a certain type of exercise. But at least in the starting, you don't want to do it, because it usually just makes you feel terrible, and it makes you feel worse. And the bad thing, I don't know if I said this before, but with POTS especially, once you trigger that system, it stays on, meaning like once it's irritated, that thing stays on for a little bit. It's not so on and off. So I tell people, like, be super careful. Like, you don't want to aggravate that thing. And usually exercise, people are like, I want you running a mile in a week or something, crazy like that. And then they try it. Like, they want to get better. So like, okay, exercise is going to make me better. They try it. They don't get very far. They flare, like everything up. And then for the next 4 or 5 days, they just feel awful.
Mm-hmm.
And then they try it again and they feel awful. And they're like, okay, it's been a little bit, but I'm going to keep going at it. And it's it'll take time, but it just doesn't work. But there's a certain time, which I'll get to in a second. So what we do in terms of treatment, if someone has POTS and they come in, there's a couple different things, but the main thing is we do treatment on the tilt table. So again, going back to the idea that POTS is a dysregulation of gravity, that the brain can't regulate or it can't integrate different or just changes in gravity appropriately. Common sense is like you have to do something with gravitational changes in treatment because you need to activate that system, or you need to subject your brain to the stress that causes all the symptoms to occur. But you have to do it in such a way that you don't fatigue the system out, or you don't overload the system so it doesn't work appropriately. So we do things with the tilt table in a certain way, and usually what we do is we oscillate, meaning we start flat, we go up a certain point, which usually isn't very much, maybe even 10, 20 degrees, to give their brain that stimulus or that stress of gravity. But then we oscillate them back down, because usually lying down is like the best position for people, like they feel the best. So we tilt them up a little bit, give them that stress, and then oscillate them right down and let their brain handle that stress. It's almost like a challenge and rest, challenge and rest, challenge and rest. Now, the tilt table alone, I don't think that's good enough to actually fix it. So what we do is, along with that, is we do different brain exercises or brain therapies with it. So if you want to think of it like this, there's different things you can do that almost prime certain areas or kind of activate or wake up certain areas that make those areas of the brain more involved in changes in gravity. So what POTS is, and usually dysautonomia, it's a dysfunction, or there's usually like a weakness or an imbalance in the brainstem. That's where the autonomic nervous system lives, or all the neurons that regulate those functions. They're all in the brainstem. And why it's common with concussions to have some aspect of dysautonomia is the mechanism of injury with a concussion, which I'm sure people have talked about before, or you may have read somewhere. It's the fast rotational shearing forces that occur on the brain that usually cause like the injuries or the most damage. And where most of those rotational forces are experienced in the brain are in the midline structures, meaning like the brainstem. So that's why it's very common for dysautonomia to occur in a concussion. So what we need to do in treatment of POTS, at least, is knowing that it's the brainstem's probably the primary area that's, like at least involved, is you want to do things that activate the brainstem, that give it a little bit of juice or a little bit of activation, that kind of wake it up, that make those neurons more active than what they already are, and then give them the specific challenge that breaks their system down, meaning that change in gravity. So that probably sounded maybe like a little complicated, but it's important because POTS, don't think of it as only like a brainstem thing where people come in and they only need brainstem treatment. A lot of the times what happens is, and why people with dysautonomia need a comprehensive neurological exam, is even if the problem is primarily in the brainstem, there's usually other circuits or there's other pathways from the cerebellum or the frontal lobe or different areas like the upper brainstem down to the lower brainstem, or even from the body proprioceptively coming up. There may be other things that are off as well. And usually what the trick is you have to figure out what isn't working appropriately or isn't working optimally or is just, like dysfunctional. And you want to do those specific therapies with the tilt table because that makes the whole system work better. And it's a delicate balance, meaning if you do it too much or it's too aggressive, you'll flare them up. But if you don't do it enough, then you're not activating the brain. You're not training it to be better involved or better regulating the change in gravity. So it's a complex thing to treat. It's not easy. There's no protocols, meaning like if you come in with POTS, it's not like we have a sheet saying this is exactly what we're going to do. It's almost like from scratch, someone comes in and you kind of have to make it very unique or very individual based on how they present. But that's what we do in treatment, and it usually works very, very well. So something I didn't say, which I probably should have started with, is I think of dysautonomia as kind of two phases. Like if someone comes in with POTS, I think of it like this is a two-phase treatment approach, where the first phase is more of a rehab or like resting phase, meaning at a foundational level, just based on gravity, their brain and their autonomics are just dysfunctional or it's not working right. So everything more that they try to do is never going to work. Exercise, being stressed out, going to the store with a million people, noises everywhere. It's just going to be too much, and they're not going to be able to do anything. So phase one is just getting that system more stable or more normal or just more optimal at a resting foundational level. And that's what the tilt table is good for, meaning they're not they're not overexerting. They're not stressing the system out. They're just lying there and they're tilting slowly up and down. And it's our job to make sure that we don't tilt them up to like 60 degrees or 90 degrees and hold them up there too long, too fast, because it's just going to flare the whole system up.
Mm-hmm.
So goal number one is you have to make that system more foundationally stable. But phase two, and this is kind of my opinion, and this is where exercise comes in, is once that system's stable at rest, you have to do something to overload it to make it work harder. Because again, just a aspect of human life, like you're going to get stressed out.
Yeah.
Whether it's, this or that, you're going to be under stress. And what happens physiologically is when you're stressed out, there's an increased demand on your system to move blood. Whether it's exercise and you need more blood to your muscles and your heart rate and your brain have to regulate how blood's moved efficiently, or whether it's just different stress and this and that, you almost have to condition, or you have to retrain your system how to work under those increased stress conditions. And that's where exercise comes in. So for me, the best way that we treat POTS, like if there was a standard example, and no one's standard, but if there was like a standard of what classically can happen, is we treat patients over 1 week in an intensive model. So we see them multiple times a day, usually for about an hour, usually 3 times over a 5-day period. Generally speaking, that's usually enough time to get the autonomics at least somewhat stable. Sometimes, like when like people leave, like if they come in with POTS after being concussed from playing sports or just falling down or wherever, usually we can get the autonomics pretty stable where they're done with phase one, and then phase two they have to go home and do other brain exercises and things, but really push that system and really make it stabilize. Because if they don't do that, then what happens is, even though they feel great, once they go out and they start driving and someone honks at them or someone cuts them off and they get freaked out, that system goes into overload mode, and then bam, feels like they're back to square one, and then they freak out because they're like, oh my God, it's back, and it's never going to go away. Yep. But I tell people that phase two, and the best way to do it, other than subjecting yourself to unnecessary stress, is you want to exercise, because exercise is basically a stress on your body. So just like with the tilt table, where you don't want to be too aggressive and just flare up the whole system, it's the same thing with exercise. You don't want to do too much too quick. And there's a lot of different exercise ways, but I think that the best way is not the long, sustained, sub-maximal exertion of like running or stationary bikes and things. I like more of the interval type of exercise. And it doesn't necessarily have to be with weights. It can be body weight stuff, or even machines and things. What you really want to do is you want to get your heart rate up. You want to get the autonomics in that stress mode, or you want to subject your nervous system to that stress, but then rest, and then make it stop, and then do it again, and then make it stop. Those short intervals of on, off, on, off, on, off, that's good. And that seems to be the best way, at least that I've found, that people can successfully exercise and get a therapeutic benefit, that they don't fatigue, they don't flare up their systems, and over time they're actually conditioning that system to work better and actually respond more appropriately to that stress, that over time they can actually just exercise for a full hour, for a half hour, and then not get symptomatic and not feel terrible both during that time or like later in the day. Makes sense, Amy?
Mm-hmm. Cool. Yeah, it totally does.
So let me see. So the only other thing that I want to say in treatment, other than it's complex, meaning you do want to evaluate the entire brain and make sure that you're addressing other issues, because most of the time, like I said, POTS and even dysautonomia is secondary with most concussions. So that's not really that's not the only thing that you really want to do. You want to do other things that treat the brain, whether it's inner ear stuff, cortical stuff, but you do want to address the POTS at the same time. The other part that's hard is because dysautonomia, and especially POTS, is a dysregulation of gravity. What it means is that every second of every single day, it becomes just, it's off. You know, whether you're lying down or standing up, more often than not, especially if there's an increased stress and gravity, it's there. So the hard part in treatment is you have to do something in treatment that is more than the gravity signals, meaning you have to actively almost overload the brain. You have to make the brain change and not let it just fall back to the pattern that it's in. So what I've found, because I've treated different ways, different clinics do different things. I've found that the best way to really treat dysautonomia, and especially POTS, is it has to be very frequent. You can't do it every once in a while. You can't, do a tilt table, or you can't do like a brain exercise. You can't do it every once in a while because it won't be enough to really change how your brain responds to gravity. Because if you sit down for 20 minutes and do something, it might be great. But then as you stand up for the next 18 hours of the day, your brain almost falls back in that same motor pattern or the same kind of mapping or the same pattern that it was in after the concussion, and it doesn't change. What happens is during that week intensive is it's so overloading in a good way to the patient's nervous system that it makes it change. That even when they leave, that like how their brain incorporates gravity is now the right way. And it almost doesn't, we don't give it a chance to go back to the way that it was. And it has to be super frequent. So especially with like the intensive model, it works very well with POTS. Because anything less, if it's like, twice a week, once a week, it's just not enough, where it might be great, but if it's not frequent enough, it usually doesn't change it.
Right.
So
do you find with most cases, how do I want to ask this? Like, is dysautonomia a permanent condition, or do the majority of cases get better? Or I know it's a really tricky.
It's a great question, meaning a lot of people ask me this straight out, and like it's hard to say because people are like, can you cure POTS?
Right.
Can you cure it? And like if you read everywhere, internet, textbooks, are like POTS, dysautonomia is incurable. There's no cure. It's only management. And that's why like the salt, the water, compression socks, that's what most people do, because they're told there's nothing you can do about it. You have to live with this. You have to manage it, so on and so forth. I'm not so bold that I want to say that I can cure POTS, but I tell people that more often than not, I can change the way that your brain integrates and reacts to gravity in such a way that it should decrease the symptoms. Meaning a lot of people can come in, stand up and just feel off, or just feel, the brain fog, the constant headaches and things like that. And I tell them, look, like if we can change your symptoms, meaning if you have a constant headache, or you have a 7 out of 10 or 9 out of 10 brain fog most of the day, or every single time you stand up you feel lightheaded, or you were concussed, and now you feel like you're so on edge that if one thing goes wrong in your day, you're just gonna like scream and yell at everybody. I tell people, and then they have POTS, and like we test for it and they have POTS, I tell them that if we can get their symptoms better and we can make their heart rate not spike, that the probability that they have dysautonomia is very, very low. I tell people that with concussions, the probability of us curing POTS or making it go away or fixing it is very, very high, because it's an effect from the injury. So going back to concussions, it's a physical injury. It's not a permanent one, meaning like it's usually an injury of function, meaning if you get MRIs and CTs and all these neuroimaging studies, they usually come back negative. They're like we can't find anything. There's no hemorrhages. There's no brain bleeds. We can't find anything. So there's nothing structurally wrong. When people freak out because they're like, oh my gosh, what's wrong? Like I feel terrible, or I have all these symptoms. And what a concussion is it's the rotational shearing, stretching forces on the brain, and it causes an injury, inflammation, poor signal relays. And what happens is there's weakness, fatigability, imbalance, or just inappropriate firing from certain areas, but it's a functional standpoint, meaning nothing died, it's just not working right, or it's weak and it stops working. So usually when POTS is secondary to that, it's not a permanent thing, meaning you weren't born with it, So the probability of it going away is really high. I tell people coming in with concussions, the probability of you getting better just from the mechanism of injury and what's really wrong, meaning you didn't have a stroke, you weren't born with, asymmetric artery system or something off like that, or you didn't have like heart defects or, things like that can change the game, meaning you have something that may never change that's always going to cause some of your symptoms. A concussion isn't like that. And if you can successfully, evaluate it, diagnose what's wrong, and then treat it, all the symptoms should go away. Almost everybody, I'm not going to sit here and say that, everybody that comes in gets better, but almost everybody that has a concussion, and especially POTS from a concussion, they get a lot better. It's not uncommon that day one, their heart rate spikes, and even after a couple of days, it doesn't do that anymore. It's not always a 1-to-1 ratio with the symptoms, meaning their autonomics might get stable, and they might still have brain fog, or they might still have some headache. But usually, especially with POTS, it's usually somewhat quick, meaning it's not going to take 6 months for it to finally break. It's relatively quick. And, even sometimes within 5 days, people feel extremely better.
Mm-hmm. Yeah, it's amazing to see how much better people can feel in just a couple days. I know for me, I think it was like 2 or 3 treatments in, and I felt so much better, so, and it's important, you kind of alluded to it, but it's important to keep up with those exercises once you go home.
Mm-hmm.
You'll work with them for the week, and then you send them home with exercises, and it's really important to continue doing those. And it's easy to not do them because you go home and you feel good, so.
Right. No, you're right. And it's just something where, like, I tell people, like, it's like training, once you're in good shape, or, you're at a healthy weight, this doesn't mean, stop eating healthy or stop exercising. But it doesn't mean that, like, if you have a concussion, you have to do brain exercises forever. It's more of because, like, sometimes people leave and they're 100% better. They're like, I feel great. I don't have any symptoms. All the diagnostic testing looks great. And I still have people do it because it's more of a maintenance thing, meaning it's working great now. I want to make sure that it keeps working great for the next few months. And then if it's great, it's like, yep, you don't have to do it anymore. But other times, if there's still even things lingering, it's super important. It's like, keep doing your exercises because it's just training. Like, you don't want to, not train it or not, keep making it better. But it's hard because, people go home and they got families and lives, and it's not easy, but we try to make it as practical as we can.
Mm-hmm.
So it usually works out okay, but we do have to stress, and we have to make sure people know that it's very important to do their home exercises.
Well, Brian, thank you so much. This, I think, was a very enlightening conversation on dysautonomia and POTS, and I really think everyone listening got some really valuable information. So thank you so much for being here today.
You are welcome. My pleasure, Amy. Thank you again for having me.